I have what is called one of the great debates, and the topic is who should take care of heart failure patient. And Dr. Joseph Alpert will defend the position that any physician can, and I will defend the contrary position that cardiologists and even more so heart failure specialists should be the ones that take care of heart failure patients. I actually was given the position that I'd like to defend because I was one of the people that felt very strongly that we needed a subspecialty, especially for patients with advanced heart failure and cardiac transplantation. I believe that heart failure patients are extremely complex. They have multiple comorbidities. There is an explosion of new medications and new technologies for them. And one of the things I'm going to show is that the ACC own recommendation for the training that a heart failure doctor should have exceeds the abilities that a generalist, a hospitalist, or even an internist would have to take care of these patients. When I talk to primary care physicians regarding heart failure, to drive the point home, I tell them if you have a patient with cancer, you would not initiate chemotherapy on your own. You would refer the patient to an oncologist, and that's who decides the approach. And I said heart failure has been misinterpreted as being something different from cancer, but indeed it requires the level of specialty that an oncology patient requires. I think that yes, there is a difference, but I think that even in patients that have chronic stable heart failure, you need at least collaboration between the primary care physician and the cardiologist. And I'll tell you why. Many of the patients that are referred to me that have chronic stable heart failure, 9 out of 10 times I find that they may not be on all the medications recommended by the guidelines, and if they are on those medications, the medications are not up-titrated to the target doses. And by target doses, we mean the doses that have shown reduction in morbidity and mortality in clinical trials. I think the biggest challenges are that, as I said, these patients not only have heart failure, but in a large proportion, they have, because of the pathophysiologic history of heart failure, they also have underlying chronic kidney disease. We have a 30 to 40% of them that have diabetes. We have COPD, chronic obstructive pulmonary disease. We have associated pulmonary arterial hypertension. We have arrhythmias, particularly atrial fibrillation. And adding to that, the fact that many of these patients are in the Medicare age, if you will. So when they become advanced heart failure patients, they also have issues that you need to address, such as frailty, fall risk, and a whole host of other problems that can arise.